We ready to go?
Hi everyone. Welcome to this week's G-Echo function, Gecko, uh, hosted by the Gastro Foundation and the Echo Project from New Mexico, obviously supported by the Indian Hub, who are our IT liaison. Um, Sessions are held weekly, and this is the last upper endoscopic session of this year. And Uh, this is going to be a good one. Um, as we know, endoscopy, flexible endoscopy, is more and more delving into um, advanced therapy. And with advanced therapy comes an increased risk of complications. And so you need to have a plan to manage these complications. And I think hopefully, I'm sure Galya is going to give us a good plan because you must plan for the worst and hope for the best. So, Gallia, over to you, and we look forward to finding out how to manage perforations in the GI tract, iatrogenic and otherwise.
Thanks, Prof. Yeah, so I thought we'd finish off the year with just briefly going through some options as regards managing a perforation once you've done whatever your intervention was. Those of you that were fortunate enough to be down in Joburg in August for the Africa HPV Cancer Consortium meeting may have heard this talk, and you are allowed to go and have a cup of coffee. For everybody else, I've got a few kind of my experiences. There isn't a right and wrong answer, so of course I appreciate if you have a different approach, but let's go through it a bit. So I think the first thing to appreciate that fortunately, depending on what literature you read, the risk for any endoscopic procedures is quite small, and for normal gastroscope, it is quite low, 1 in 11,000, and that is quite significantly lower than the 5.8 to 6 per 10,000 for colonoscopy. So it's not usually something we would include in our consent for a normal G-scope, but of course that changes significantly if you're actually performing some form of intervention. Now, that said and done, on the flip side of the coin is that 60% of esophageal perforations are iatrogenic. Now, that's quite a big number. And more concerningly is that the mortality of these perforations can be really quite significant. And that mortality obviously increases exponentially as the delay increases. So your delay in treatment is by far the most important survival predictor. Fortunately, almost two-thirds of perforations will be identified though within the first 24 hours. So my first recommendation to you all is that no matter what you do, always somewhere in the back of your head have a suspicion that you may have performed an intervention that's resulted in a perforation. So even if it's a very simple, unexciting, easy dilatation, it is our routine practice to always go back down with a scope and just see what you're left with. It's sometimes surprising in which patients you actually have quite a significant mucosal tear. So what I've put up there for you are three different post-intervention check scope pictures, kind of mid-esophagus, all benign dilatations. And you'll see that in the first picture, you've got a sort of 6 o'clock longitudinal mucosal tear, and you can see some kind of, probably with some imagination, some muscle fibers underneath, and then slightly lower down, a second mucosal tear, probably about 8 o'clock. If you're concerned, you can always put some contrast down, but that to me is quite acceptable, and I wouldn't do anything there. Slightly different appearance on a different patient. Again, quite a clear mucosal tears at 9 and 3 o'clock. Both again rather superficial, not much bleeding, and I wouldn't have any concerns there. On the right of your screen, I can't see a thing. just a lot of bleeding, and clearly this is the one that we all have to worry about. There's something going on there. Mucosa, yes, it can bleed, but if you get a muscle tear, you get quite significant bleeding. So this is the patient where if you cannot see anything, make sure you put some contrast down. Something sneaky is happening here. So worry if you can't see. Too much blood, there's a perforation until proven otherwise. So what about your intervention risk? Obviously, if you are performing some sort of resection, that risk for perforation increases. Your EMR resection perforation risk is quite small, so it's 1.1% according to most articles that have come through, but that does warrant an explanation during your consent taking. ESD, so endoscopic submucosal dissection, that goes up to 7.2%. And just from my side, the duodenal perforation rate in this scenario is by far the one where I worry most. So duodenum is always a sneaky one, and be very careful. It's much thinner than you actually think. Stomach is still quite forgiving. As regards the classification of deep mural injury, it's best classified according to the Sydney classification. I've put that up there. It's quite a nice article. The the authors and the where you can find it is down at the bottom of your screen. But essentially, it's graded into 5 different types. Type 0, there's no concern at all. And then as your depth increases, just look below. There's then the appropriate image trying to show you what that would look like. As soon as you see a patch of white, and you might say, oh, that's a burn mark or whatever, that's the one you need to start worrying about. It means you are potentially going into the deeper layers. Here, quite clearly, there's a concern for a full thickness, and anybody can see that you've got a full perforation there. So that's a type of grading. I would, to be honest, probably put a clip on there, or at least be very cautious, and keep a good eye on the patient post-procedure. Definitely not send home. For most of our ESDs, we keep the patient overnight. And here, quite clearly, you need to do something, put a clip on that or whatever, and that's a no-brainer. That needs to be sorted. The next question is, when do you actually go about repairing your perforation? Obviously, as soon as you see it. You have to use what's available. So as Prof. Thompson alluded to in the beginning of this talk, you need to have a plan in case something happens. So I would never recommend going ahead with a dilatation or whatever if you've got absolutely no access to either stents or clips. You need to have a backup plan because perforations will happen. But you have to use what you've got. You must use what you're comfortable with. And of course, there are appropriate tools for the specific perforation. So not everything works for anything. Through the scope clips, over the scope clips, or stents. And of course, there's combinations that you might use. I'll quickly take you through other options, which are a little bit fancier and a bit more tricky, such as an endo loop with a through the scope clip closure. I've put a question mark in front of the fibrin glue. I would not put that first in any endoscopic repair, especially in the acute scenario. It's mentioned, but it's not, yeah, I wouldn't put that up there. Then, of course, in our scenario, we do not have the option for endoscopic suturing, but if you're in a unit where that's available, clearly that's a fantastic thing to do. I thought we'd go through a few quick cases just to show you what might happen and how we manage them. These are cases that we've perforated in our unit. The first one is an interesting chap, a young male, 21, who came to us with a refractory peptic stricture. Every second week, we were dilating this thing. I'm not sure if it projects nicely, but there's just a fluoroscopic image at the dilatation. There's a scope, some contrast, and you get an impression of a good 4, maybe 5 centimeter tight stricture above what is here clearly a fairly large sliding hiatus hernia. And that stricture, absolutely pesky. We dilated repeatedly, just back to square one. At some point, unfortunately, clearly on the fluoroscopic image, You can see a massive amount of free air. You do not even need to put contrast down. Clearly, we've perforated. So immediately place the stent. It's a fully covered stent. We have, for the most part, a preference to fully covered stents. Yes, they can migrate, but they're equally favorable in that you can remove them quite nicely. The stent is placed, and at that same intervention, we then put contrast down. The scope is a bit deep here, but you should be putting contrast down from the top and allowing the contrast to kind of pool at the proximal flange of your contrast to ensure that you've actually got sealing. And what you see here, beautiful sealing, contrast goes down, absolutely no leak. So that was quite early pickup, sorted. We then admit the patient and keep him on IV antibiotics for a few days, broad spectrum augmentin, and then allow the patient to swallow liquids almost immediately. Obviously, watching for signs of sepsis, but that usually does the trick. It's all about picking it up early. What about the duration? How long do you leave your stent over that perforation? So the recommendation is between at least 2 to 4 weeks. And if you've got a slightly larger perforation, well, then they recommend 6 weeks. We kind of average at about 4 weeks, to be honest, mainly because it's a timing thing for the patient to come back. It's a bit difficult if they're from far. Size of your stent depends very much, obviously, on the actual pathology in the background. So for this patient, we have a 4 to 5 centimeter stricture, and somewhere within that, there's a perforation. So my stent should always be at least 2 centimeters longer proximally and distally of whatever you're trying to cover up. Um, yeah, I would always tend to go a bit longer in these cases. I also think in the benign strictures, the stents actually dilate quite quickly, those areas of fibrosis or stricturing, and you get lots more migration. And in that case, a slightly longer stent might just be a little bit better. Yeah, I mentioned that you should confirm at the time with contrast that your leak has been sealed off. The esophageal stent placement is probably as effective in that early iatrogenic perforation scenario as if you were to go and open that chest surgically. Clearly, from a patient point of view, the stent is much more preferable. The migration risk of these fully covered stents, especially if you've got a perforation where there isn't actually an esophageal stricture to keep it in place, you can pop in a over-the-scope clip, or if you're lucky enough to suture it in, you can fix that in temporarily. I'll speak a little bit more about the stent fixation a bit later in the talk. Our second esophageal perforation. This is a recent lady, and yeah, has really been quite a problematic and unfortunate situation. She's in her early 30s with presentation initially with a completely obstructing esophageal squamous cell carcinoma, resectable, but in view of it being a squamous carcinoma, we opted to give her definitive chemoradiation, which she completed quite well. And her post-treatment PET CT, luckily for her, no residual tumor. However, unfortunately, when she came back for review, she still had complete dysphagia, fully dependent on a nasogastric tube, which we'd placed prior to the completion of the radiation. And we suspected on swallow and clinical suspicion that she had a long radiation stricture. And we subsequently wanted to also see whether there genuinely was a complete response. And we did an endoscopic balloon dilatation to 12 millimeters. I must say, though, she is a very small lady, but still, you would think that 12 millimeters isn't too bad. But clearly, once I pulled out the scope, I had a nice, big, juicy perforation that anyone couldn't miss. Horrible scenario. We stented her immediately with a long stent, with a view that the stent would cover both the perforation, which was quite at the proximal end of the radiation stricture, and then to cover the distal stricture as well. She was quite miserable with the stricture. She's quite a short lady as well as being a petite lady, and it was causing her quite a lot of globus sensation. We did a contrast swallow 48 hours later, and there was confirmation that the perforation was still nicely sealed. But what you'll note immediately is that as the stent has expanded open, there's been some distal migration down. She completed her 5 days of augmentin, and we discharged her on a soft diet with treatment for reflux and advice to keep herself upright after meals. As you can imagine, this close to the OG junction, there'll be a lot of volume and acid reflux. We booked her for a stent in 4 weeks. This is her stent, her fluoroscopic image in the GIT suite. Stent came out beautifully, no issues at 4 weeks, but she immediately started coughing. And we popped down a little bit of contrast, and there you have it, filling up immediately, quite clearly, a tracheoesophageal fistula. What's bad about it is that the level of the TOF was demonstrated here at endoscopy. You can see the carina there sitting just under a centimeter above the carina, so a really stupid spot to sit. Why did it happen? Well, first of all, we had the stent migration, and as you know, the flange of the stent is the widest part of the stent. And with her very small petite frame, the maximal radial force of our stent flange was sitting just above the level of the carina. She's really a tiny lady. She weighs under 40 kilograms. So I think clearly this was a pressure necrosis effect. Um, yeah, tricky one. And just for those of you that are interested, if it's an acute thing, you can go and patch it. If it's a small hole, you can patch it. Her nutrition and her radiation and the previous cancer, with all that inflammation, we decided that we didn't have evidence to suspect a recurrence of the cancer, fortunately, and we were also terrified of going into that chest. So we actually offered to divert her, meaning if this is what you started off with, so we're sitting with a tracheoesophageal fistula just above the carina. We opted to divert that. This means that we tie off essentially the esophagus at the top and below the trough. And what happens is that back wall of your esophagus then collapses ideally and becomes your posterior wall of that fistula region. And then, of course, you have to pull up a gastric tube such that she can now have continued GIT continuity. So that back wall stays, that back wall of the esophagus stays. So that's our way of dealing with tracheoesophageal fistulae, usually the big, large, benign ones that we see with TB. This is how we do it. But in this case, where it was an iatrogenic TOF from a stent, we opted to do the same thing. So back to how do we treat this? So whatever you're doing, you've got to absolutely see what you're doing. So if it's bleeding profusely, there's no point in getting a box of clips out. You have to then put a stent, do a swallow. You have to use whatever is appropriate for the situation. I wanted to take you through a little bit of my thoughts about clips. This is quite old, I think 5, 6 years old now, but at that point already there was quite an assortment of through the scope endoscopic clips available. And what you need to look for is a couple of things. First of all, for me, the most important thing is how wide does it open? You would think that the wider is always the best option. Not necessarily, but you definitely don't, in my opinion, want a clip that, for example, opens only 5 or 6 millimeters. That's kind of pointless. So everything is 11 millimeters and more. I tend to like the slightly bigger ones. I think they're quite maneuverable despite the width of the opening up. The bigger they get, though, then in the esophagus becomes a bit of a pain to maneuver them over a perforation. The other thing that is looked at is the actual length of the jaw, and that obviously you can imagine, the shorter your jaw, the less of a juicy bite of mucosa that you can probably take. The clip length and the tail length, yeah, I think To me, I must say the practicalities of that are less of an issue, but the trade does kind of punt that a bit. But to me, those are the two things I look at, the width and the jaw length. And of course, the ease of deployment. What you need to do, very importantly, when you have a small perforations, through the scope clips are fantastic. They work very well. Also, when you've electively created a perforation, for example, in a poem, these are beautiful. What you have to remember is to do it like you would zip up your jacket. You start at one end, work your way to the other end. There is absolutely no point in trying to get the middle together. My recommendation is also that your first clip starts at the apex and you must work from the most distal aspect of the perforation up towards yourself. The other trick that you can do is when you see a perforation, the first thing that happens is you get a tachycardia, you start sweating, you get anxious, and you put in as much air as you can so that you can see what you're doing. That, however, stretches your mucosal edges apart, and then you can't really get nice closure. So relax, suck out the air, and then your approximation of those mucosal edges will be a bit easier. Don't stress too much. Take your finger off the insufflation. Here's what I was trying to explain to you. That initial apex clip to zipper up that thing must be really distal, and you don't actually need to catch that first aspect of the mucosal tear, whatever it is. Once you put that first clip, those sides of the mucosa come together beautifully. Let me play that again, and then you can zipper it up very nicely. It's that first apex clip that makes or breaks your closure. So take my word and put it a little bit below your actual perforation. It'll make it so much easier. There's a new clip out on the market, which is quite a wide clip, but that's not the important part of it. The important part of this clip is the actual teeth.
Hi, Sandy. Galya.
Galya looks as though she's frozen.
Yeah, it looks like it from her side. Let's just see if she comes back on. She actually dropped off the meeting.
Let me just see. I'll try and get her on WhatsApp.
Okay.
Hi, I'm trying to hook up. It just died. I don't know.
Yeah, no, I don't know either, but yeah, we'll wait for you.
Okay, cool.
Thanks.
Bye.
Yeah, everyone, she has had trouble and she's dropped the connection and she's going to rejoin in just a minute. So you can twiddle your thumbs and think of some questions and you can post them in the chat, please. I'm sure you must have a few. You can think of all the old bad things that happened to you when you were doing endoscopy.
Hi,
Everybody
can
has
you hear me?
complications. We can
Yeah,
hear you. You're back
can
again. Do you
hear
want to
you.
share again?
Hello?
We can hear you.
Hello? We can hear you.
Okay, sorry. I'm so sorry. I'm not sure what happened there.
Don't
Let's
worry.
rec Sorry. Okay.
We've got a question in the chat saying if you want to take it, Salah.
Can you
Okay.
see?
We can see that.
Galya, carry on, yeah?
Okay.
We'll take the
Sorry.
question later.
Yeah.
Okay.
Sorry,
We'll-
everybody. I'm not sure what happened. Let's start back. So the mantis clip is a little bit different to the other through the scope clips in that it's got a nice, juicy, big jaw. And what you can do with that is quite clever. You can hook your tissues very deeper, much deeper through the mucosa than you would normally. So you hook one side, close your clip gently, move the tissue across to the other side, and then clip the other side. And this one's different. Here you can clip one or two in the middle of your perforation, and then you can plug little normal through the scope clips in between. I've had very little experience with this, only practice on pig models, and I must say it's very nice. It does work well. The problem with this clip is it's hugely expensive, so it's actually prohibitively expensive, and I would keep one or two if you can for a situation like this. It is not a clip for a routine closure or a bleed. It's very pricey, but it works also only, unfortunately, when your tissue or your perforation is fresh, because you need that mobility of the mucosa to come across. Otherwise, there's no point. A fibrotic old perforation is not going to work. This is just an example of what it looks like endoscopically. These are obviously not my pictures, but what you see here is a fresh ESD incision that's been made, quite a large thing. And what that tooth application kind of the jaw allows is for you to catch and pull across. So you close it gently, pull it across, and then you can bring those edges much nicer together, and then you fire the normal smaller clips in between. This is another case I quickly wanted to run through with you. This is a 37-year-old lady. She was known to us for some time with a caustic stricture of the pyloric channel going through to D1. And we recognized the perforation only by doing a fluoroscopic image at the end of our dilatation and noting, oh goodness, there was now a whole lot of free air. We were unable to get the scope through that strictured area and placed there, I hope you can see, we placed there's the free air. We placed, and the contrast, just a magnified view. I'm not sure if you can appreciate, here's a duodenal stent, covered stent, unfortunately a bit of contrast. And then what we've done is we've placed an over the scope clip to try and fixate that stent in place. Now this is a very unclear image. There's a lot going on. There's a ton of contrast. There's air. You can't see what you're doing because of the contrast. But this is the reality of it. It's not a nice situation to be in, and you can often struggle with visibility. So there's just that stent. The other thing that you must be very aware of and be very careful of is the degree of and the actual speed that a tension pneumoperitoneum occurs once you've perforated. It's really quite quick, and the patients develop a kind of a compartment syndrome. This is unforgivable that there's a scenario where somebody did a CT scan of a tension pneumoperitoneum. That's really bad. But here it is, not our picture, thankfully. But the ideal is obviously to deflate immediately with a large diameter venous catheter, such that your patient can recover their cardiac output and so forth. And it's also a reason why you should be, if you're doing interventional endoscopy, use CO2 for your insufflation. But pop in a needle. You can save a life like that rather than waiting for a scan and popping in ET tube. Deflate that abdomen. Stop insufflating. Over the scope clips are fantastic. I must be honest. I think they have really changed the way we deal with certain scenarios endoscopically. For me, I suppose for the makers as well, but they clearly resemble a bear trap or an animal trap. The idea is that you are, with one single clip application, able to close a fairly large perforation. The concept is that pretty much like a varicose bander, it's the applicators applied to the tip of your scope. It's applied under quite considerable amount of tension. There's a string like your bander that goes up through your channel, and as you tighten the string, that over the scope clip snaps up and over whatever you've applied to your tip to. Here's a nice example of how you can close it. You cannot go much bigger than 3 centimeters. I think 3 centimeters is already kind of on the edge of it. But what you see here is a beautiful fresh perforation. So a full thickness excision was made or whatever. But the idea is that you again pull the tissues towards yourself and then apply the tip of your over the scope clip over all the edges of that mucosa and then seal it off. It is permanent, it stays there. What you need to do that, I hope the video is playing, you need a twin grasper. Quite a clever little design. The idea is that, again, like with a mantis clip, that you catch one side of the mucosa, close your grasper, and then draw it across to the other side. And let me play that again if you weren't watching. And then draw it across to the other side. Here's a schematic representation. Your twin grasper comes down, you catch the one side, move it across, and with the other little arm, you're able to catch the other side. What I have done by accident once is not made sure that my twin grasper is all the way back up and beyond the tip of my over the scope clip. Because if you slam that clip onto your twin grasper, everything is stuck. That's far from ideal. So be very sure that you pull your twin grasper right up into the cap of your application device. For chronic fistulae, they are also marketed as a means of closing them. You can see quite clearly that these edges are never going to come together very nicely. There's going to be tension there. The recommendation is that you irritate and inflame a little bit with coag or whatever those edges, such that they might grow better together. You can close it. It looks great. You can come back there in a week though, however, and that fistulae from my experience is for the most part back. So in my opinion, chronic fistulae, closing them with an over the scope clip, very seldom effective unless it's a teeny weeny little hole. For tracheoesophageal fistulae, a bad idea because your membranous part of the trachea is ever so thin, and I think for the most part you'll end up with a bigger hole. So I think use it in chronic fistulae with a lot of caution. There are some disadvantages to the over the scope clip, although I've said I think they're really great. The availability. Not every unit has them. And the big thing there is clearly the cost. At the moment, I think they're just under 6,000 Rand. You need to be familiar with the device, and you've also only got one chance to close it effectively. If you misfire this thing, you cannot get it off. So you've really got to be comfortable with it and be very sure that you've got it on the right place. And remember, as I said, with the trachea, for example, there's the risk of underlying structures being clipped in with the application. It's permanent. I'll show you just now how you remove it. So you can remove it, but you need equipment from the company that supplies it to come in, such that you can fragment that clip. Endoloop closure, this is quite useful for larger gastric and obviously also for colonic perforations. Here's a schematic representation of what you do. You open an endoloop over your perforation, and then with a multitude of little clips, you're going to clip over both your string of your endoloop and the edge of the mucosal defect. And then when you pull close the endoloop, the idea is that you scrunch together that mucosa by pulling those clips together as they are attached to the edge of the mucosa. It's fiddly, I'll be honest. I've only tried it once or twice. It is really fiddly. And this picture makes it look very easy. It does work. I can't say it doesn't work, but you need nerves of steel to keep going. This is not my picture. My pictures look nothing as beautiful as this. This is from an article where I think it's a bit of an overkill. I mean, you can see that thing is maybe, at best 15 millimeters. You could have used just normal through the scope clips, but the concept is there. You take your endo loop, lay it down, catch it with a clip on the edge of the mucosa, and then you can pull them all together with one application of the endo loop. It does work nicely, but yeah, it takes a bit of practice. The other thing which I've not tried, but which I came across when putting this talk together, is that pretty much similar like you would a surgical omental patch for a perforated ulcer. If you've got a perforation within the stomach or perhaps small bowel, wherever you are, or even colon, and you see omentum poking through, you can catch it with an endo stitch if you've got that, or even with a clip, and clip that omentum to the edge of your mucosal defect as a patch, exactly as you would do normally with a surgical stitch at laparotomy. Again, that is a perforation you probably could have closed without doing that. Nonetheless, it's a nice thing to be aware of. When you are performing ERCPs, your perforation risk is obviously also there, and you've essentially got 4 different areas that might perforate. For type 1s down here, these are classified as those that are on the lateral or medial aspect of the duodenal wall. And again, the closure technique is pretty much like we've spoken. If it's a small thing and you're able to visualize it nicely through the scope clips, depending on the size, you might use a couple, or a single over the scope surgical clip might be appropriate. If it's a larger one and the access is bad or you can't actually see what you're doing, this is something that you should consider repairing surgically. Type 2s are the periampillary perforations with some retroperitoneal free air, and you should be able to see that immediately on your endoscopic fluoroscopic view. The only thing you do there is stent that duct, and you might consider, if it's a considerable amount of air, whether you admit well, you should admit, but whether you give a course of IV antibiotics and whether you keep them NPO for some time. The type 3s are the slightly higher ones in the bile duct or even pancreatic duct. And again, biliary drainage with stenting is the way to go. Type 4s are the retroperitoneal microperforations where you've only got free air. The patient is pretty fine and well. You can again consider putting in a biliary stent, but that's where you actually can't see where you've made the perforation. You can probably manage that conservatively too. We've got a D2 perforation to briefly discuss here. A 49-year-old lady, and she had an ERCP with a D2 lateral wall perforation, which was recognized at the time. But she came back with a delayed presentation of continued leak, and she had a laparotomy. The drain was placed quite posteriorly, but unfortunately she continued with a high output duodenal fistula. And what you can see here, not a very great image, but contrast in the stomach. Going down to the D2 region, our perk drain is still in place. Whoop, straight into the bag lying over the drain with no contrast flowing anywhere distally. So here what we've done is placed a covered duodenal stent, and you can see from the contrast absolutely beautiful closure of that perforation. The problem with duodenal stents, if they are fully covered, is quite clearly the migration risk. So here's an image of the same patient 2 weeks later. Now you've got contrast going all the way down quite happily into the proximal jejunum. No residual leak, which is great, but that stent has now clearly migrated further down into the jejunum. You can be unlucky and that stent can get stuck somewhere and cause a perforation, specifically if there's been a prior laparotomy and there are adhesions. You can also be very lucky in that that stent might pass without incident at all. So in the beginning, when we started placing duodenal stents, here you can see a partially covered where the flange is actually uncovered. In my infinite wisdom, I thought that one little mucosal through the scope clip would do the trick. Clearly, absolutely wrong. You need one gastric peristaltic wave and that thing will pop right off. I then thought to myself, okay, let me put one either side. Equally ignorant from me, that pops off straight away as well. So mucosal clips and stent fixation do not work. What you need to do is unfortunately get a clip, ideally here an over the scope clip, which gets into the muscle layer. You need to transfix into the muscle layer. You can stitch it if you've got that opportunity. We don't. So we would use an over the scope clip. The over the scope clips look a little bit different to the ones that seal the perforations in that there is no vacuum created and there's actually a little gap in the applicator device, and that is such that you can fit the device over the edge of the stent. It's quite clever, and there you've got a clip applied. Works really nicely, and trust me, that stent will not move. The problem comes now 4 weeks later when you want to take out that stent once the perforation is healed. You then need to liaise with your rep who sells these over-the-scope clips because you need a bipolar fragmentation device. You apply it to two sides of the clip. It's quite spectacular when it's dark. It's got a beautiful image, and you fragment both sides of the clip. These clip edges are quite sharp, so it's not something you should leave lying around. The fragmentation device comes with quite a long over the scope cap, and you can actually grab those fragmented bits, pull them into the cap so that when you come up and pull out those bits through the esophagus, you are doing so safely and not causing any secondary injury to there you can see it's fragmented now. And that little piece we would pull up and out through that cap, and then you can quite safely, as per usual, pull out your stent. So that's one way of doing it. Quickly, an overview as regards our perforations. I think endoscopically, anywhere you can do it with early recognition and being comfortable with what you've got. Clearly, the sooner you do it, the better. So ideally, for the most part, at that initial endoscopic procedure, you should be doing it. For the closures, we've recognized it immediately and it's quite small and there's very little time for contamination. Endoscopic closure with a small clip is fine, or over the scope clip. If there's been contamination, all good and well, still close it endoscopically, but then liaise with your interventional radiology team to pop in an external drain. The problem comes when it's a delayed presentation and there's either severe sepsis or your patient is quite unwell. Then I would not consider doing this endoscopically anymore. I think that boat has sailed. You may then consider contacting your surgical team and performing a surgical washout with external drainage, however you want to do it. Specifically for the OG junction locations, yeah, again, if you have the ability to recognize it earlier, this is a place where a covered stent works very nicely. The problem is that migration risk. So clipping it in with an over-the-scope clip is recommended according to these guidelines as well. Once there's severe sepsis, you can still put in your stent, but if it's up in the chest and you're worried about mediastinitis, well, clearly you need to speak to the upper GI or the thoracic team to get into the chest and wash that out and leave some appropriate drains. Something else that's come about and is very popular internationally, specifically for esophageal perforations at the anastomotic site, is the Endovac. It's also used quite often with our colorectal colleagues. Very nice concept. The newer design is that you've actually got your sponge and your vac around an already positionable stent, covered stent. So everything goes in as a single unit. It's really nice. Super pricey. I think it's in South Africa, it's going for about 45 to 50,000 Rand per shot. And if you think you have to replace that every 4 days at a minimum, that's really expensive. So in our situation, we are fashioning these Endovacs ourselves. They're a little bit more tricky to put in. Alternatively, we are sneaking out the colorectal endovacs and using those in the esophagus. The length does overlap, so we're able to use that. But the endovac is great for dealing with already confirmed contamination. Works very well, but the issue is that you keep having to replace it. And really, waiting longer than 4 days gets so stuck. It's incredibly difficult to get out. So that's the option for associated sepsis. Here you'll see a scenario in the esophagus with some stitches in the background, and there's clearly an anastomotic leak there with some sepsis. The stent is put down as per usual, but you've got then the ability of that extra drainage for the endovac and the sponge. You can go through it with a scope. The shaft is actually big enough to allow for your scope and liquids, but it's a lot less in diameter as to a normal stent. So that's quite a nifty way to do it, but not always practical for our resource-restrained environment. Another option for an endoscopic management of a situation where you've got associated sepsis is to assist by placing a transgastric drain with an endoscopic approach. So you can do it from externally, you put in your drainage tube from outside your perforation, and then you assist endoscopically that an internal drain, similarly as for the endovac scenario, you're trying to drain both sides, and that you can then place endoscopically. Yeah, be careful when you do it because you are now creating another defect, but I think it is a salvage option to remember for some really tricky scenarios. What about success of endoscopic closures? I think the sooner we spoke about it from the start, your endoscopic success is good if you pick it up early and if you've managed to avoid a considerable amount of associated contamination. So if you pick it up early, it can go very nicely, very well. Your stomach is quite forgiving with closures. There's great vascularity, and the maneuverability of your mucosa and gastric wall is quite something that aids in these closures. Esophagus, not bad closure as well, but there you can at least have the benefit of the fully covered stents. The colon, obviously, as you can imagine, depends very much on where your perforation is, and similarly with the duodenum, whether it's a free perforation or a retroperitoneal one. I think important to be aware of, there are reasons why you may not be able to close something endoscopically. And it's obvious that if your edges are ischemic, necrotic, inflamed, or most importantly, if someone asks you to close a perforation and there's been some time that's passed, those margins are stuck. There's fibrosis that's starting there. You will not be able to safely pull them together. So that's one thing. Time and fibrosis is against you. Then, as soon as you've got a perforation larger than 20 millimeters, you may be aware that you're going to struggle. As we said already, delayed diagnosis is an issue. And then, of course, positioning. The one tricky spot to close is your proximal esophagus. Patients don't tolerate stenting very well. They get a tremendous globus sensation. And then if you put in clips there, the top sort of couple of centimeters are quite sensitive, so a tricky one to close if you've got a proximal esophageal perforation. So yeah, to finish off, this is my last slide. For all small perforations, be they wherever they are, through the scope clips. If it's smaller than 10 millimeters, is probably your primary way to go, except for an ERCP where you're going to pop in a stent. If it's anything between 10 and 30 millimeters, although 20 millimeters starts becoming tricky, there you can consider putting an over the scope clip, if it's the esophagus or stomach. Depending on where in your jejunum, you might be able to do so too. And similarly in your colon, and of course, if you have the luxury of suturing, by all means. Then esophagus, as we said earlier, if it's a bigger perforation, by all means, put in a covered stent, but remember that you have to fix that thing into position. Otherwise, that thing slips very quickly. The more distal your perforation and positioning of the stent, the sooner it will migrate because of the proximal contractions. I think that's my story. Thank you, Prof.
Thanks very much, Galya. That was quite a tour de force. Slightly different from the one you gave at the HPB Association. Nevertheless, very comprehensive. There's one question about, again, I think you
Okay,
covered
I'm
it
not
at
sure
the
if
end
there's any
there about
questions.
what
I don't see anything in the. Oh, wait, there's one in the
it
chat.
is.
Let me just check.
I think you tried to answer that just now, but please have another go at it. Do you see it? It's what is your recommendation for a high UES, upper esophageal sphincter perforation?
Yeah, it's a those are the tricky ones, those high ones. Uh, yeah, the usual strictures that perforate up there are usually high as well. So to put a stent there is usually tricky, difficult, and again to keep it in place is almost impossible. If it's an very early small perforation, I think probably what I would try is through the scope, small clips, and over the scope clip, very tricky to apply so high up because you don't have the angulation. I've not had much success with that. Um, yeah, you might end up putting in an endovac or even draining the neck if it's that problematic. Not an easy situation. I don't have a good recommendation there. It's a, yeah, very horrible spot to fix.
Yes, I think one of the things that I think you must be aware of is when you have difficult intubations, because I think prevention is one of the cures for that. And again, if you have an undiagnosed Zenkers, you can actually end up with a scope in there. So beware of people who've got dysphagia, especially if they're a difficult intubation. And you may want to do that under fluoro with guide wires. And again, you just have to think about it. We once had a patient who came who'd had a previous Zenkers done for an EUS for some cystic pancreatic neoplasm. We couldn't get the scope down his throat, and we abandoned it and went a different route. So I think it's really important when you have difficult intubations in dysphagic patients who you think the level of dysphagia is high. Just be very careful about how you intubate with your scope. It's not designed as a dilatation device. You must do that, and I think go to the fluoroscopy room, especially if you have access to it. I don't know if
Agreed.
that's yeah.
Yeah.
And some of these, I think obviously now that there's more and more interventions going on with full thickness defects, and some devices that actually are encouraging actually doing that.
Yeah.
So that obviously again means that individuals who are doing these interventions who need to have adequate training, but they also need to have these escape clauses and all these clips and devices available in the vicinity if you're doing this. Otherwise, you need to have extremely good surgical backup for some of these. I don't know if there's any other questions. If anybody has any questions they would like to ask, they can unmute and go ahead and ask Galya. Looks like you've answered all their questions, Galya, and given them lots of tips going forward, especially those tips about the through the scope. Um, can I just say one thing about that? The other thing is that some of these through the scopes have different deployment mechanisms or slightly different. You want to be very familiar with how they release and how they open and close so you don't misfire them or use five or six instead of two or three.
Yeah.
So make sure that your assistant knows exactly how the deployment works and whether they're also rotational or not, as most of them are now.
Yeah, I think for those, sorry to interrupt, Prof. For those
Yeah,
of you
sure.
that are potentially looking to get yourself some clips for your unit, be careful of the very cheap clips. Remember to look at the length of the arms. And then one thing some of them don't tell you, that they are only, you can open them once and you can close them once, and that's it. Then they have to be fired. So you need a clip that you can open and close, open and close, open and close, and adjust so that you get a nice bite before you fire it. So those very cheap clips, absolute waste of time, unfortunately. They are pricey.
Yes. No, they're definitely you need to know how they deploy and exactly how they function.
Mm.
So thanks again, Galia. That's taken us to the end of the year. You've done phenomenally well with all your talks and other individuals who've contributed during the year. And again, this is recorded and it can be found on the Gastro Foundation website. Once again, thanks to the Echo and Echo India team. And I think next week is pediatrics, so you have the little ones next week. And for those of you who are attending that, please tune in because I'm sure it will be valuable. Thanks again, Galia, and goodbye to you all. Have a good Christmas and New Year.
Thanks, everyone. Bye-bye.
Bye.
Bye.